topics and opinions expressed in the following show are solely those of the hosts and their guests and not those of W4CY Radio, its employees, or affiliates. We make no recommendations or endorsements for radio show programs, services, or products mentioned on air or on our web. No liability, explicit or implied, shall be extended to W4CY Radio or its employees or affiliates. Any questions or comments should be directed to those show hosts. Thank you for choosing W4CY Radio.
Welcome to the Ask Good Questions podcast, broadcasting live every Wednesday, 6 p.m. Eastern Time on W4CY Radio at W4CY.com. This week and every week, we will reach for a higher purpose in money and life, as well as a focus on health and wellness. Now, let's join your host, Bonita Bell-Andersen, as together we start with Asking Good Questions.
Welcome to the Ask Good Questions podcast. I am your host, Bonita Bell-Andersen, and we have a fantastic show today that I think you are going to really, everybody seems to be interested in this topic. We are going to be talking about GLP drugs. We are going to be talking to a doctor that has a very fantastic whole outlook on this, so you are going to want to stay tuned and listen in on this. So with that, I'd like to invite Dr. William Summers to the podcast stage.
Thank you, Bonita. Thanks for having me.
Thank you so much for joining us today. Well, let me tell you a little bit about him. He is, this whole thing with GLP-1 drugs has gone from a diabetes treatment to a cultural phenomenon, really. And with that fame comes a flood of myths, scare stories, sales pitches. We are going to get rid of all that today. Dr. William Summers brings 4 decades of medical experience and a clinic owner's front row view to a candid discussion about weight loss as a medical issue, right? Not a matter of willpower. We're going to tackle the muscle loss debate. We're going to talk about the side effects, the new pills. Actually, I never do this because I usually don't want to say a date, but today is July 1st, 2026. Medicare has made this available, and so there's some ramifications around that we are going to talk about. So welcome, Dr. Summers.
Thank you.
Tell me where are you coming from?
I'm sorry. I'm from Birmingham, Alabama, and I let everybody know I'm double boarded. I say double boring. I'm boarded in OBGYN and obesity medicine, and I've had the privilege of practicing obesity medicine for about 15 years as a major part of my clinical practice.
Wow, awesome. Well, for someone who's heard the brand names, how could they not? There's all these things on TV, isn't there? And
there's
what exactly is that GLP-1 drug, and how do they work in the body?
Well, I think the best place to start for people to understand what we're talking about, it was discovered in recent years that when anyone is overweight, we can measure 4 neurochemicals in our body that are messed up. And when they are messed up, and we eat, and we all have to eat, and these chemicals are messed up, we gain weight unfairly. So the first one, a very important one, GLP-1, stands for glucagon like peptide 1, a small peptide. And this is made in our intestines. And every time we eat a meal, this peptide goes inside our brain and makes us feel satisfied or full, the satiety hormone. And it goes outside the brain to help regulate blood sugar. Blood sugar regulation is critical to normal weight gain. So with the GLP-1 being messed up and that was identified, then this medicine came along that will help fix that, to actually put that back into our body, elevating the GLP-1 that is low, and you get full quicker, regulating your blood sugar. And this was just a huge breakthrough in the medical science for weight gain and obesity management. It came also secondarily that another chemical identified called GIP, gastroinhibitory peptide made in the intestine, really helps regulate blood sugar, is messed up. So then they have a medicine, I just call them 4 buttons are messed up. We have the medicine, semaglutide, known as Ozempic, Wegovy, fixes 1 button. We have the tirzepatide, known as Mounjaro for type 2 diabetes, renamed Zepbound, fixes 2 of the buttons. And the fantastic drug, which will be released hopefully next year, also made by Eli Lilly, will fix 3 of the buttons. It's known as retatrutide. These are all injections, and they all have pretty much, we could talk about 1, 2, or 3, and they have pretty much the same side effect profile. But they are definitely all, in the sense, good for the heart, and heart disease and stroke are the #1 killer in this country. They treat the abdominal obesity, and 200 diseases are associated with abdominal obesity. So I think we are onto something like the penicillins of weight loss, just getting started with a great future ahead.
Well, one of the things that somebody said to me not just recently was, being overweight is a side effect of, so it's like we're going to be talking about the side effects today, but just being overweight is a huge side effect and risk to your health in and of itself.
And in almost all circumstances, that is true. There is there's a clinical entity called the healthy obese patient. So I just want to clarify that not everybody with obesity has medical issues, and let's put that out there. But most of us with obesity, we do have medical issues, and it's good to just be educated about that and understand what is available, and then choose options individually, lifestyle options, and even if it goes there to medical options, but to have an understanding of what we're doing, what we're taking, and what to expect.
So you've been practicing for 40 years.
Yes.
How did a medication that was originally meant for diabetes become a weight loss tool?
Well, it's interesting because it was all developed, as you just mentioned, with the beginning of advanced studies for type 2 diabetes and the pathophysiology. We gain weight, chemicals are messed up. We gain more weight, chemicals messed up. And as we go up the weight gain ladder, the top of the hill, we have type 2 diabetes. So the pathophysiology for obesity and type 2 diabetes is pretty much the same road. So we have a drug that'll fix that road, but the drug gets 2 names. One drug will get 2 names. For a diabetic patient, it's called Ozempic, and for a diabetic patient, Mounjaro. But for a weight patient, Wegovy or Zepbound. So it was just by, I think, incidental or accidental or observational studies that, hey, when we do everything for diabetes, we're also doing the weight loss. And then the parallel pathophysiology was recognized. And so those 2 are studied together.
Well, this whole thing with treating obesity, because I think a lot of times people have been shamed thinking it's just a willpower problem. It's I'm just a bad person. And so there's a distinction between it's all your fault and this is a medical problem. So does that distinction matter to you when you're trying to treat patients?
This is where I get on my soapbox. My passion goes off the chain. This is a disease. Obesity is a chronic disease. Just like if you had some type of strep throat and problems, and we now know, well, we can use medicines or treatments for that. This is no different. And this whole stigma and this discriminating and shaming people anywhere for any reason, it's wrong. And I just get so frustrated and passionate defense, just like the understanding of the disease. Education to understand the disease will help us take the blame and shame, which should never exist in obesity or anywhere in our culture, period.
Well, you originally, you're an OBGYN, right? But
yes.
Did this, I just want to, walk us through, did you kind of start moving in this direction as you, you were, you basically started out with traditional medicine, but this is kind of taken over, right?
Well, as you mentioned, I've been had the privilege of having a practice for 40 years with OBGYN. My patient population are women of all ages. And we've had a lot of medical training and surgical training to start a practice. But what we never got trained in is what we're talking about right now. And when women come in to my practice from the beginning and the get-go, they would ask me about their weight problems and their weight gain. And it became very frustrating because I didn't have any tools in my toolbox. And so going in and trying to dive deeper into what we had very, very limited tools, many of which we thought were good and turned out later not to be good. So the discovery of now what we know, the facts about the disease of obesity, it excites me because we can target that like any other disease. So that it was just by the patient population and the problem that women now, and I always will mention this, and it's really unfortunately true. Men gain weight, and we don't like the weight, but women gain weight and don't like themselves. And that's misogyny driven. It's wrong. It should never be a double standard, but it is real. And you can ask men and women, this is true. So with women, with a population affecting their confidence, socialization, sexual responsivity, then there was something. So I've always been looking for something to help. And now when we had tools that really do sort of parallel the pathophysiology, treating like any other disease, efficacy-driven studies, it excites me to have something in a toolbox to help a patient that comes to me.
Right. Well, let's talk a little bit about some of the myths that are out there. Let's talk about what's really true here. So what's the single biggest myth that you wish you could just cut through right now? Get rid of it.
Oh, wow. There's so many of these. I think that the biggest myth overall is that when people say, well, if I use these medicines, then if I stop them, I will become a diabetic. And I'm like, oh, okay. And it's like, what? We are all sort of on the diabetic hill. Remember that an A1C in 1964 was 5.9, and you were a type 2 diabetic. And we have all been going up the diabetic hill. And so now an A1C of 6.5 is a type 2 diabetic. And as we get bigger and more belly fat and more insulin resistance and more belly fat, we're just on this snowball getting bigger. So people have this something in their head that since the medicines are used to treat diabetes, and the pathophysiology overlaps, are used to treat weight loss, in their head, they think, well, I just don't want to be on these medicines forever. No, you don't have to be. Well, if I stop this, am I going to be a diabetic? No, you're not going to be a diabetic. So I understand where the confusion comes from, but all of this, hey, we're going to prevent diabetes with these, and losing weight will put you lower on the hill. And that, yes, if we don't make health style changes to maybe keep us in a better place, we're all going to be diabetic, because 50% of our population today would be type 2 diabetic if we use the original 5.9 A1C. That's considered pre-diabetes now.
Wow.
But okay, so that's the one that I just want to educate to clarify. I get all types of questions about, well, my hair will fall out, and people read about that. And there's unfortunately a small population of people, when they use one of these medicines, there's a direct effect on the hair follicle. It's not permanent, but it scares them. And then there's an indirect effect, because the weight loss that occurs, and this you can say compared to bariatric surgery and weight loss, the weight loss is a stress to our body. We are designed physiologically to gain weight. Our body wants to gain weight. So losing weight, we go into like a little mini shock in a way, affecting hair. But for the most people, we don't need to worry about that, and we address that individually as a real problem when people have concerns about it. There have been a host of compound medicines in the past, things that should not have been on the market, eligible for use by patients, research grade medicines being given in desperation, a salted version of semaglutide, which is not the formula, that is the base type peptide that they make. But so a lot hit the market fast, and that created a lot of confusion. And people have a needle aversion, and I probably do. But I would say this is if I could do it, anybody can do it, because you don't feel this. But if you just hear the word needle, panic. The pill forms are available. What myths do you hear? Let me ask you that, because I address this all the time. But the one that I get most common, I'll be on these forever. I'll get diabetes if I stop. My body will be dependent on these. No, when you get to a normal weight, we go back to normal physiologic functioning, and your GLP-1 will function on its own normally. And the GIP and the glucagon and the amylin, these chemicals that I said 4 buttons are messed up.
Well, talking a little bit more about the mental side of it, sometimes people will say, oh, you're cheating, or you're just taking the easy way out. Do you think that's even, I can't imagine it, but I know it happens.
Well, penicillin was discovered in 1941. And if people had strep throat in 1930, they got leeches if they had a severe infection. And when we understood, hey, that's a bacteria, and now we have an antibiotic to treat that bacteria. In 1941, penicillin, the first antibiotic to treat a bacterial infection. So that would be like saying, now that we understand this disease and we have a medicine, if you had strep throat, and you say, well, I'm going to prescribe penicillin. It would fix that for you. And they say, oh, you're a sign of weakness. You should not do that. Well, of course we should do that. Everybody understands that. The thing that is most common and very common, 10% of all women, is a low thyroid, hypothyroid. And if a patient comes in and I do routine lab and I say, oh, your thyroid's low, I need to put you on thyroid medicine, no one says a word. Like, of course you do. I need a normal functioning thyroid. So when I say, hey, your GLP-1's low, and you put you on medicine, they're like, oh, wait a minute, because of it's new. And I understand that. And we have a right to question. I love that people don't just do as doctors say, process, educate, make your own decisions. But we just got to look at this as the disease that it is, and not medicine. Don't start with medicines, but start with understanding the disease and what can I do to make it better for me, not to be more accepted, not to be less shame, which should never happen. It's really just to have a higher quality of life.
Yeah.
And that's our goal.
You, okay, here's another one for you, Dr. Summers.
Okay.
I'm going to lose a lot of muscle if I take one of these.
Okay. All right. Now there is some truth to this if we don't understand the disease. When we start having our meals stored as fat, we make fat. That is called lipogenesis, make fat. Now, when we lose weight, what is fat in the first place? You can't be alive if you don't have sub-Q fat. We use it as a reserve fuel. So anytime we don't have enough intake, then our body will use that fat. We use it between meals to get us between meals. We store fat and use the fat as fuel, and then we store fat and use it as fuel. But now we're storing too much. So anytime we go from sugar to fat, lipogenesis, that's easy. But when we go fat to sugar, we must have amino acids in that process to make the sugar. Gluconeogenesis, if you want the big medical word, fat to sugar. And to lose weight, that's what happens. We take the fat, fuel, reserve fuel. We got too much reserve fuel. Let's start using it and get rid of it. And when we get rid of it, amino acids are needed. Amino acids live in one place in our body. That's muscle. And of all the organs in our body, if you think, how fast is my motor running? What is my basic metabolic rate is the term that is used, but say motor speed. This is muscle dependent. So just to understand it in a simple way, if you wanted to eat a lot more, just get you a little bit of muscle. But if you want to get in trouble and get in a hole and quit losing weight, lose a little bit of muscle. But what I'm telling you, as we lose fat, we have to lose muscle or we can't lose fat. But that's where here comes the superhero protein. And I would say for all women, 120 grams a day, that's extraordinarily higher than any probably meal that you would fix. For men, 160 grams a day. And why that? The three macros, fat, protein, and carb sugar. You put fat in your blood, it's gone. And if you put sugar in your blood, it's gone. But protein breaks to amino acids, and they stay in our blood a long time. The macro that stays. That's why proteins give us satiety, that stays in our blood. So if we can increase the superpower of taking protein, keeping amino acids all available in our bloodstream, we will not break down muscle. So the secret to success, really, with all of this, is not medicines. It's understanding the types of sugars, and it's not just calories. You know, if there's 4 grams in a calorie of sugar, and 4 calories in a gram of sugar, and 9 calories a gram of fat. But there's types of sugars, and you get a lot more weight gain with the simple refined processed sugars than you do with the complex sugars found in fruits and vegetables. So I could probably spinning all off the rail here with this discussion, but the point will be with maintaining muscle, it's just it's a super amount of protein, requiring all those protein little drinks between meals to maintain, so that when we do lose weight and go fat to sugar, when we will not break down our muscle, and we can take the amino acids available in the blood to create what we call gluconeogenesis, fat to sugar.
Well, that sense? Yeah, that makes sense. But I think something practical to take away from that is probably a good idea to be doing some strength training.
Absolutely. You know, cardio for the heart, resistance and strength training for muscle building for weight loss. And they're both applicable in our health needs, but when we're talking about weight, we're going to talk about building muscle. And the point what you just mentioned is if we don't really pay attention and just start losing weight, we're going to look like the quote Ozempic face is what was called, and the muscle loss in our face. And that can be prevented by not allowing the muscle loss occur with fat loss, which it inevitably will. So we get that. So that's a fair concern, and it's not a myth, but a myth that the discussion out there that can definitely be controlled with the education of this, if that's what I'm trying to say.
Right. So man, it's on TV, it's everywhere, all the information about this. How can a regular person tell the difference between solid medical information and all the noise that we're seeing on social media?
There is so much noise. And when I got into this in a serious with a serious look, I decided the best thing for me is to offer no gimmicks. I'm not trying to sell anybody anything or advise everybody take medicines, but there are evidence-based studies, clinical trials done with control groups, double-blinded perspective going forward to look at results. So we can show population results that are great to sort of make these discussions. So I think anything outside of a scientific, double-blinded perspective control trial with results, it's hard for me to endorse. I mean, so the noise is try this and make this, GLP-1 jello. And I mean, I just try to just put that aside. I'm trying to say there's evidence-based medicine. We have a disease, and I can give you sort of population studies, but population studies are not necessarily applied to every individual. So I can say, well, there might be this percent of nausea, but you might have higher than that or lower than that. But we can base what's real from evidence-based studies. FDA approved, generally it's the strictest sort of committee, and I'm proud of them for being strict to make sure that what is told to the patient is actually coming from adequately, the properly collected information.
Well, what do you feel is the biggest, what side effects are the ones that you most commonly see?
Okay. Just to clarify, we mentioned 3 medicines: semaglutide, tirzepatide, and retatrutide. All right. I would just say in the general bucket for understanding, the side effects of these are all going to be about the same, plus or minus. Number one side effect by far is nausea. All right. Now, every one of these medicines are going to have dose titrations. You'll do a level 1 dose, a shot once a week, no nausea or side effects. You go to level 2, up to level 3, level 4. And when I give you these numbers, let me clarify, and I do clinical trials, phase 2 clinical trials in dosing. When a patient enrolls in a study, there's algorithms, they are forced to go up the ladder, or they have to get out of the study. So they make them week 1, week 2. So I'm going to tell you, in population studies, nausea is about 40%. In real life, in my patient population, it's a much lower number. And it is something we have to watch for. But there's antiemetics like Phenergan or ondansetron, promethazine. I shouldn't say Phenergan now. But you do level 1. If somebody's like, I'm a little bit nauseous, we keep on level 1 for 3 months if we need to. It's all about dose titration. So nausea, number 1, all 3 medicines: semaglutide, tirzepatide, retatrutide. Constipation is number 2. And with women in general, there's a constipation, kind of an IBS-C, we call it, irritable bowel syndrome constipation, and that's real. And there are over-the-counter preparations you could take, and I always recommend Miralax, the new thing that people are using, and it's been found in some observation studies. Magnesium glycinate is good for this to take along with it if you tend to have constipation. But the third most common side effect is diarrhea. And it's very nice when you have somebody that has a little bit of the C problem and gets a little bit of the D problem, and they are normal on the medicine. So you have to see again, people might do level 1 on any of these, go to level 2, and then start having constipation. Then it's time to go back down to level 2 and let that sort of rest a while. Most of these occur because of the dose gets a little bit too strong. And the fourth one will be vomiting. So the nausea is number 1. The vomiting is down 4 or 5. Indigestion is pretty common on these medicines, and you can take tons of Rolaids. And just to say, GERD in itself, gastroesophageal reflux disease, we call GERD, bad heartburn, indigestion. Well, people have that, and they'll think, well, this indigestion is bad. Can I take this medicine? And any GI doctor will tell you the best thing for long-term management of GERD is to lose that belly fat these medicines target. So even if they're already on these H2 blockers like famotidine, or if they're on a PPI we call omeprazole or Nexium, the Protonix medicines, even if they're on those, these medicines make increased indigestion. Take some extra Tums or Rolaids, because losing weight will hopefully get you off medicines altogether. Right. So those are the big ones. And we can go down. There are some that we've kind of, people have kidney disease. They're good to take these medicines. I always say you could be on a list for a kidney transplant and take these medicines. You can be on a list for a liver transplant and take these medicines because they don't get metabolized or excreted through the kidney or liver, like about every medicine. And when you're on medicines, these don't get into the bloodstream and grab onto other proteins and bump other medicines off of proteins. So we don't have to worry about drug-drug interactions and protein bonding. They go to their receptor sites, and when they get their job done, there's an enzyme that effectively removes them, and peptides are put back into the amino acids where they came from. So we could talk about lesser. So any sort of, we call it an adverse event, any sort of thing that would happen when you're on a medicine, let your provider know, because there are some things that are not as common, we don't need to talk about, but anything like if you start itching on behind your left ear and you never did that, let your doctor know that. And that's just hypothetical, I just made that up. But anything that would be new on e-medicine, let your doctor know. And sometimes if there's a list.
There's another tweak. There's another tweak to this, and that's compounded versions with mystery additives that are claiming to fight like side effects or muscle loss.
Yes.
How should people be worried about that?
This is just maybe more my opinion, and I would think I could extrapolate this a bit from what I read about what the FDA likes and doesn't like. I'll go to semaglutide. Semaglutide is made by Novo Nordisk. A Denmark dude is the one who developed the process, base recombinant process, to make this peptide. And Novo Nordisk bought that. And all this is made in Denmark, except for more recently factories in our country in North Carolina. Base recombinant. And I could describe how it was made. I used to be a chemist, but it's a certain way. Now, when the compounds first came out, they were doing, they added salt to it, and like a salt version, semaglutide acetate or semaglutide additives. I will just not get the chemical terms, but that wasn't exactly what Novo Nordisk made. The compounders now, here's the legal part of these. Semaglutide was bought by Novo Nordisk, and they put up millions and millions of dollars into studies, so they own the patent on that drug. When they ran out of the drug, then we saw this surge of like an early generic, is the best way to understand it. And it was coming from everywhere and not really regulated. Going back to your question, the semaglutide that was being made, all of a sudden, like, hey, we got these salt versions, we got these research grade, and not really quality inspected. And everybody was, maybe they were effective, can't comment, but that needed to stop, and it did stop. Now, some of these bigger pharmacies, I'm not going to mention names, started making this themselves or manufacturing or purchasing it manufactured. And now they're going to be in a patent infringement, because when semaglutide, Novo Nordisk branded Ozempic, Wegovy, their storages are packed back up. We should not be legally using anything with that branded medicine. But it's been out there and everywhere and hard to control. So some of these places started adding chromium to it or B12 to it and justifying it through a lot of lines of rationale. The FDA, and this is why I'm extrapolating, and it's not a law, and every state has variations of what they can do, but the FDA is like, don't put any crap in there. Just use the stuff that's supposed to be used. Base recombinant semaglutide, tirzepatide had a shortage and compounds came out. And so it's kind of like, well, you've got a patent on tirzepatide, but you don't have a patent for tirzepatide B12, B6 chromium that we add to it to make it our own. And I think that's all kind of in the gray zone of legalities. And I'm not going to mention the name of the pharmacy that's meant very national with Super Bowl commercials, had to settle an agreement with Novo Nordisk to quit doing those things. So in other words, so added things, I can't say that they are bad, but I don't think they're offering any advantage. And if somebody needed B12 for, they think, more absorption efficiency, I think that's why they say they put that in there. We can get B12 without putting it in that medicine. They're trying to make it their own so they won't have a patent violation. And I think that's where that all stemmed from, but it's not like better. I mean, there's some crazy stuff. I mean, people take a little bit of this compound and mix it with a little bit of the semaglutide, mix it with some tirzepatide, let's put some retatrutide, and then we'll make it our own. Oh, yeah. I mean, people, I'll come in, they'll come in like, this is half semaglutide and half tirzepatide. Oh. I have no clue what that's doing, you know? And so it's just, and there are some things out there like microdosing. I think that is a very, very legitimate thing for patients to do, that if smaller doses work, hey, save money, use smaller doses. Yeah. But I think the quality of the medicines, the branded medicines, I always prefer. And in cases where it's allowed, a sourced compound from the right place that's inspected through all the agencies and the pharma agencies that have to say, okay, this is good enough to use, then use those. But we don't need to change it to make it our own, in my opinion.
So, Dr. Summers, who is a good candidate?
Okay.
If they do this in a smart, intelligent way and they ask some good questions, Who's a good
Okay.
candidate?
All right. All right. First of all, I want anybody that feels like they need to lose weight. And by the way, that's 76% of our population.
Yeah.
I think first to educate, how do we go from 10% obesity at World War II and be at 40% obesity today? In other words, like if there's something that causes, let's get rid of them. You know,
Yeah.
let's get the black mold out of our house and know what's really caused us to escalate that sort of intensity of an incidence frequency. But so health style changes. I call health style because I like that term better than lifestyle. But let's look, how do we get there? We're all doing it. What's in our food that we need to know and make choices individually what work for us? And if these kind of things, and maybe and we're all screen timing and less active, and maybe we just consciously try to say a few more of this, a few more steps, maybe some resistance here. And if these things are not working, here are the eligibility requirements for most medicines. Body mass index is the term that we use, you know, when you put the height and the weight in the formula. But a BMI of 18 to 19 to 24.9 is normal. 19 to 24.9, your BMI. At 25, you're overweight. At 27, you're more overweight. At 30, it's considered obesity. 35 would be class 2 obesity. So let's put these numbers. If you have a BMI of 27 and you have what is called a comorbidity, and there's a string of things: hypertension, diabetes, sleep apnea, types of arthritides, GERD, there's a list. If you have 27 and something wrong with you because of that weight, then you would qualify for medicine. All right. If you have a 30, obesity by definition, then you have no questions asked if you want to use a medicine. For these are the FDA requirements nationally: a 27 comorbidity and a 30, no questions asked. I believe you already introduced earlier about the Medicare, and we'll talk about that.
Yeah, let's talk about Medicare, because that is like today's the first day.
I would stand up and applaud the congressional team that has recognized this is a disease. Our insurance and health insurance covers diseases, and this is disease. It's not just like, well, do you a favor 30? This is a disease. It should be like hypertension disease, diabetes disease. I mean, but they are now covering for Medicare patients with Part D, and that's the drug coverage. And it's not 100% of all plans, but it's a great percentage. And I just went through eligibility. Medicare will say if you have a BMI of 27 and only one BMI of 27 and pre-diabetes, an A1C over 5.8 or 9, depending on your lab. If you have a 27 and pre-diabetes, they will offer you coverage for medicines. If you get to a 30, which, like, no questions asked, typically across the board commercially, if you get to a 30, you must have at least one comorbidity: hypertension, diabetes, sleep apnea, GERD, something that's recognized that will get better, but it's that at 30 is not no questions asked. You must have something wrong with you. At a 35 or higher, then no questions asked. So it's a little bit different for the providers. And as we mentioned, with this new coverage, I want to give them a standing ovation. This is so needed. These are safe medicines at any age. They're FDA approved down to 10 years, and some of the medicines at up to any age, because losing belly fat will give us the highest quality of life. And I could talk all day about how that happens and why, and how that messes up our body's protectors when we have this sort of fat right here in our body. So, and they target that. But eligibility, so who's a candidate for somebody that feels like their efforts have failed? And okay, let's use the penicillins of weight loss and target the disease, because there's some still things on the board that are not necessarily things that target the disease per se, but there's other issues with emotional eating and things that we can get into. But when we're talking about GLP-1 medicines, if nothing has worked for you, let's do this. Neurochemicals are messed up. When people have bariatric surgery let's just go to surgery. Neurochemicals are messed up. The surgery and the weight loss, the surgery itself normalizes these chemicals through a discussion I could have with you. Chemicals are messed up, and when they remove part of the stomach, the negative influencers normalize these neuroendocrine buttons. And when they do the Y loop, the Roux-en-Y bypass, removing that piece of the intestine, normalizes the chemicals. So weight loss will be ultimately concluded in normalization of the neuroendocrine chemicals, is why the 3-button hitter is going to give us the same now results that we get with a gastric bypass or gastric sleeve or gastric bypass. I mean, it's really fascinating. But who needs medicine? The question: failed efforts, qualifications, understanding education, look at what we're eating, what we can do. Maybe we can move this and over, eat what you like, change it and like it with boundaries and medicines, and understand what to look for. And I consider these the safest medicines of any medicines I've ever used. If for any reasons in a GYN OB population of patients and now weight loss, these are safe medicines, and it's exciting. They are safe. And yes, we hear all about the anecdotal, this happened to me, and some real, some not real. But always understanding that anything individual can happen to you needs to be presented and talked about to make sure it's just could be like something more serious or not. The really only serious things I tell people that we really need to watch for with these medicines would be pancreatitis. They work on the pancreas. And if you get nausea, that's pretty common. But you get nausea and epigastric pain or pains in your stomach shooting to your back, or you're sicker than you should be with nausea, we need to do some blood tests very, very early. And I would say in my practice in obesity for 15 years, I've never had a patient to develop pancreatitis, but I stopped the medicine and prevented a lot of cases that could have been over that many years.
Well, I think what you're saying, what you are saying is, if people are going to be taking this, they should be followed. They should have a medical professional that is following them.
100%. A person that understands what they're prescribing and and responses from the patient. And it shouldn't, I can't comment good or bad. I don't do telehealth, but I lose that three-dimensional contact when I see a patient, which I prefer in my practice. But the telehealth agencies that are just sort of mailing these to you, they might be great. So I'm not saying they're not good, but it's probably not for what I would prefer as a practice. But my patients, they know they can call me 24/7. And a lot of them unfortunately have my phone number, but I do want to know if they're experiencing something, because a lot of times it's really reassurance, but there's times that I need to, we need to say, hey, don't do the next dose, you come in here. And by doing clinical trials with some of the bigger pharmaceutical companies, I've kind of learned through experiences outside of my clinical practice, like things that have taught me to be safety always first, more careful than the boundaries. Like they'll let certain an amylase go 3 times normal. If my amylase in a patient goes 1 point over normal, I stop and we have to discuss. So safety first, always safety first. I'll say it again, safety first 3 times. Everybody hear that. It's always the most important.
So, we've been talking about Medicare and how this is becoming approved through Medicare plans. A lot of the people that are going to be listening to this are that age. Is there anything? Yes. Is there anything that an older listener should be understanding or be aware of with considering doing this?
Okay. When I talk about age, I think we're all beautiful, healthy, and wonderful at any age, and we all deserve a high quality of life at any age. Yeah. And that in per se, and as we age, the cardiovascular risk is way increased. And the number one killer in the population we're talking about is going to be heart attack and stroke. Well, if we can do anything to reduce that, and that's a whole nother discussion, but these medicines, if you get on medicines, lower clinically evidence proven, lower the incidence of heart attack and stroke. Definitely can claim by the semaglutide Novo Nordisk people. Takes a while to do the studies. The tirzepatide, Eli Lilly, they're finishing the studies. But I'll just say, and I'll put my name on this one, all these medicines will lower our incidence of heart attack and stroke, which is affecting the population we're talking about. Anybody that's aging, most of the weight, we get a little belly fat and we wake up and there seems to be more the next day and then more the next day because the buttons are messed up. And if we can fix these buttons and have a tolerant, and just where people, I like to say, if you take these medicines, you shouldn't even really know you're on them, except for you can't eat very much. I don't think people should walk around burping and sulfur burps and GI symptoms. We're doing too much medicine and we need to stop it. But because these are common side effects. But so I would say get rid of the fear and don't be scared of at least a discussion and an education. So do these patients in the population we're mentioning have inclusivity for these medicines? 100%, 100%. Because lowering that weight, that just seems to be, I just is part of aging. No, it's not. It's a part of our culture, going from 10% obesity to 40% obesity. Yeah. But these inflammatory and immunological problems and cardiovascular risk affect the population greater. So don't be scared of the medicine. It's not necessary for everyone, but don't be scared of the medicine. But look at our life, because we can all be a little bit more careful, and we can all, like you just said, do some resistance training, some muscle building, preservation, not like exhaustion stuff, just everyday stuff that will make a difference.
Well, another thing, and this is just me noticing this all over the place. There's pills and there's injections. What do you think is the best way to do it? The injections, or if people don't like sticking themselves with a needle, is it going to be better? Is there a difference between the two different methods?
Well, let's talk about this. When we talk about these medicines like GLP-1, GIP, glucagon, let's say with glucagon and peptide 1 and GIP. These are peptides. Peptides are pieces of a protein. If your house is a protein, your front door is a peptide. These are small things. So insulin is a peptide. Yeah. Peptides have never, ever been able to be swallowed, because we swallow a peptide, that little bitty piece of little amino acids attached to each other, break down, and there's nothing to go into the bloodstream. So it's all about what do we get into the bloodstream. So any peptide, all through history, any peptide is injected. You cannot swallow it. It will be degraded in stomach acid. So they've got this now new revolutionary way to put this peptide into a pill, semaglutide. It started with Rybelsus. They kind of tweaked the capsule is put in. So here's the thing. The medicine, what is in our bloodstream is what's going to get to the brain and then go outside and regulate our blood sugar. When you swallow a pill, the people that did put a peptide into a pill, my question was, why didn't they put insulin in a pill? Because everybody that needs insulin, it'd be a lot easier to get that to where it needs to go. You know what I mean? But they put these peptides in a pill. And so we started out with, now semaglutide was Rybelsus for diabetes. They tweaked it a little bit. Now they're going to get rid of Rybelsus and they're going to have oral Wegovy and oral Ozempic, because they tweaked it. It's a little bit better absorption than the old version, but you've got to get it into your bloodstream. And so I know when people do an injection, it's going to the bloodstream. I've always preferred that. The diva part of oral Wegovy is that when you swallow that pill, you got to read. They don't really announce this, but you got to swallow that pill, and they'll tell you not to eat for 30 minutes. I tell every one of my patients, swallow that pill and don't eat for 1 hour, because the absorption efficiency is at about 90-something% at closer to an hour, not 30 minutes. But they're trying to sell the drug, and people, I don't want to take that pill and wait an hour. But if you're going to take oral Wegovy, wait, at least wait the 30 minutes. No medicines, no sips of coffee, water, so you got to take that with so many ounces of water, the least amount of water you can take, and swallow that and wait. Foundayo is now made by Eli Lilly. It is also just a single button hitter. It's a GLP-1 receptor agonist, and they got this sort of absorption thing down. So you can swallow Foundayo and eat breakfast, coffee, go whatever. It doesn't matter what time of day. It's absorbed even in the context of competition. And so we have now 2 single button hitter oral pills, Wegovy, Foundayo. And it makes sense to me, like, well, if I could just say anything we're given free, give me some Foundayo. There might be in population studies a little bit more GI upset. I haven't seen it in my patient population, but I always worry about, are they getting the medicine in their bloodstream to do the job? And I know when they do the injections, I know they're getting a constant dose each time, because it gets into the subcuticular, picked up by the capillaries, gets into the bloodstream, and they got their dose that day. And there's no diva application with that. And the needle, listen, I'm the biggest wuss you'll ever meet. Seriously, I scream at bugs, and I did never do a shot. And I can do this injection. And I think, okay, if I can do it, America, you can do it, because I am a wuss.
Well, Dr. Wuss, Dr. Summers, I'm a wuss too.
I am a wuss.
We're out of time. You know what? I think I'm going to have you come back, because I really think that we should get into behavior around eating and all of that. And so we've run out of time right now. So for our listeners who want to explore this honestly, what would you say would be the first thing that they should do? As a, just your closing remark now, because we're out of time.
Believe in yourself. If you believe in yourself, you can do it. Don't do anything to make yourself better, because you're already great. Do anything to make you have a higher quality of life, to see your kids, grandkids, your puppies, all their grandpuppies. Quality of life. Believe you can, and it will happen.
Awesome. Well, okay, we're going to call this part 1. We'll do another part 2, and we'll kind of see how things go. I think I'm going to call my insurance company, and I'm just going to find out what they tell me.
Okay, absolutely.
Yeah, and then we'll come back and we'll revisit more. I want to get more into behavior, what you're actually putting into your mouth, so that you have long-term success with this.
Yes. I don't do anything self-promotional, but I did put a video series out, which is nothing but education. I will not know if anybody watched it. It was just to help providers and patients understand the disease of obesity. I discussed these medicines, basic, just simple principles of what types of sugars, and we talked about the protein and kind of just what to expect. And so if I thought what we're really missing, the big picture is just everybody, hey, we need to understand this is a disease. And we don't make fun of people with diseases, and we approach that medically. And if your thyroid was messed up and I said you needed some thyroid medicine, you would say, thank you, doctor. And I would like to think that we would understand that in the same conceptualized way that we treat this as the disease that it is. And not all diseases need to start with medicines, really none do. But we need to do medicines before we do any surgery. That's a fact.
You're right. Well, we are out of time. So Dr. Summers, thank you so much for joining me today. I think we've asked some good questions. I think that we've hopefully cleared the air on this. And as always, there will be an information sheet about Dr. Summers. And go out to YouTube and look at his. I've been out and looked at his informational series. It's really useful. It's on YouTube. So with that, thank you all for joining us today on the Ask Good Questions podcast. And we will see you next time.
Today's episode is over, but we did ask good questions again, didn't we? Don't miss out as we broadcast live every Wednesday, 6 p.m. Eastern Time on W4CY Radio at W4CY.com. Join Bonita Bell-Andersen next week for more conversations with experts on finances, retirement, behavioral finance issues, health and wellness, and more. Until then, remember to ask good questions.